بسم الله الرحمن الرحيم. صباح الخير. Good morning everybody. Good morning everybody. We are here to discuss term and preterm premature rupture of membranes. Premature rupture of membranes means spontaneous rupture of membrane before onset of the labor. It's about 10% in all pregnancies. If the premature rupture of membrane occurs less than 37 weeks, so it is a preterm premature rupture of membrane associated with significant maternal and fetal morbidity. What about the causes or the etiology? It's either idiopathic or more common to be due to infection. The infection is usually ascending from the lower genital tract and usually caused by streptococci beta hemolytic type. So the most common risk factor is the infection, decreasing the tensile strength of the fetal membranes, usually by Trichomonas vaginalis or streptococci, gram-positive bacteroids streptococci. Cervical incompetence may be another factor, polyhydramnios and multiple pregnancy, local membrane defects, and cigarette smoking. So, uterine overdistension with a decrease in the progesterone action, or a cervical problems like cervical incompetence, breakdown of maternal-fetal tolerance, stress, or unknown or idiopathic infection, vascular causes, residual sensitivity, and uterine overdistension. What about the hazards? Premature labor. Labor usually starts within few hours after rupture of membrane. If it occurs before 37 weeks, so it will be a preterm labor and a premature neonate. Placental abruption may occur if it is a sudden gush of amniotic fluid. We usually, in a polyhydramnios case, a case with overdistended uterus, excess amniotic fluid, sudden gush of fluid, sudden drop of the blood pressure, it will lead to placental abruption or accidental hemorrhage, which may be associated with either intrauterine fetal death or maternal morbidity or maternal death. So, rupture of membrane in cases of polyhydramnios and multiple fetal pregnancy, there is a sudden decrease in the amniotic fluid pressure, placental separation, accidental hemorrhage. Oligohydramnios, if labor didn't start and all the fluid passed down, so there will be an oligohydramnios. Infection is one of the very important complications of premature rupture of membrane. Ascending infection from the lower genital tract will cause chorioamnionitis, maybe septicemia, septic shock, and puerperal infection. And also neonatal infections, either skin infection or respiratory-like pneumonia due to the chorioamnionitis. So, prolonged rupture of membrane may be easily complicated by ascending lower genital tract infection in at least 20% of cases. Maternal chorioamnionitis, there is fever, rigor, malaise, abdominal tenderness, the passage of a yellowish discharge, infected discharge through the vagina, which is another problem. As it regards the investigation, maternal leukocytosis is very important, maternal tachycardia, fetal tachycardia, uterine tenderness, foul smelling of the amniotic fluid. Also, total and differential leukocytic count here is very important. Leukocytosis shift to the left, which does mean that the staph to the segmented more than 6%, and toxic granulation. These three characteristics are very important of any bacterial infection in the body. Leukocytosis, shift to the left, and toxic granulation, with increase in the C-reactive protein and ESR. We see here, it's usually an ascending infection from the lower genital tract. This is the chorioamnionitis, ongoing infection, bacterial ascending from the genital tract. What about the clinical presentation? We have here to differentiate between increase in the vaginal discharge or passage of urine accidentally, like stress incontinence, which sometimes associating primigravidous pregnancies, and between rupture of membrane. Rupture of membrane, it does mean a sudden gush of water that will goes to the legs and to the clothes, while the secretions are usually mucoid. You have to change the underwear every 3 to 4 hours, and stress incontinence with urine odor of the passage of the fluid. So a sudden gush of a significant amount of colorless fluid through the vagina may be colored. Sometimes it's greenish, especially in breech presentation. Sometimes it's reddish if associated with some blood. Sometimes it's yellowish if it is associated with pus, so it's not almost colorless. By inspection, it's a clear, colorless, odorless fluid flowing out of the vagina. If I do a PV examination, should be avoided to minimize the risk of infection, but we have to do it for the diagnosis, but for once. You see, in the ultrasound, you found here decreased amniotic fluid. The baby is in contact with the placenta and uterine wall. There is no amniotic fluid here or there. There is no pockets of amniotic fluid. So, Polyhydramnios, it does mean that the amniotic fluid pocket for longitudinal less than 2 centimeters and the amniotic fluid index less than 5. This is the sum of the 4 longitudinal pockets in the uterus. If it is less than 5, it is Polyhydramnios. Polyhydramnios is a very ominous sign and usually associated with either hypoxia or placental insufficiency, and termination of pregnancy usually should be done. How you confirm with the diagnosis? If you put a speculum here, there will be a fluid coming from the posterior fornix, colorless, odorless, clear fluid. This is the proof here. If you do a nitrazine test, it's a paper-like. If we put it in this fluid, usually it will be in the blue side, and this is definitive of rupture of membrane. If I take this fluid and I leave it to dry under the slide, I will find positive ferning test, palm leaf appearance. عامل زي ورق الشجرة كده زي ما انتم شايفين, positive ferning test. This is the amniosure. It's a measure of the placental alpha macroglobulin. It's a very sure test to be done to conclude that the membranes is ruptured. What about the management? The management here, it depends on the gestational age, the presence of uterine contractions, and the presence of infection. If uterine contractions occur, labor should be continued, no use of tocolysis. Antibiotics should be given to guard against chorioamnionitis. So here, if labor starts, let it to continue. Contraindicated to use tocolysis. You give antibiotics as a prophylactic. If chorioamnionitis or infection develops, cervical culture, intravenous broad-spectrum antibiotics, and termination of pregnancy should be done. This is a very important item. If you had a patient with chorioamnionitis, termination of pregnancy is a must to guard against septicemia, septic shock. This is a very important item. So if there is no chorioamnionitis, no leukocytosis, no shift to the left, no toxic granulation, no fever, no passage of pus or tenderness, and there is no labor pains, which sometimes may occur, if early preterm, less than 34 weeks, we can do conservative management by hospitalization and observation. Temperature should be taken every 8 hours, pulse for tachycardia, observation for the passage of more fluids, total differential leukocytic counts every 48 hours. We give intramuscular corticosteroids 6 mg every 12 hours for 48 hours, total dose 24 mg corticosteroids. This will enhance the lung maturation of the neonate. We do cervical culture and we give an antibiotics. If late, more than 34 weeks, or in other countries, term more than 37 weeks like our country, the pregnancy termination, either by induction of labor or by cesarean section. Usually, the preferred route is the vaginal route to decrease the risk of spread of infection from the uterus to the peritoneal cavity and the development of peritonitis. So here, vaginal delivery is more preferred than cesarean section. What about the amniotic fluid? Amniotic fluid is a clear yellowish fluid that surrounds and protects the fetus inside the uterus. What about the source? The main source is the fetal urine. The main source is the fetal urine. But other sources continuously produced by and absorbed by both fetal and maternal surfaces, more fetal contribution. The most important is fetal urine production. Amniotic membrane and transudation from the fetal circulation, maternal placental chorionic membrane and transudation of the maternal circulation. The amniotic fluid volume gradually increase with the gestational age to the maximum of 1 to 1.5 liter about 34 weeks to 36 weeks. After that, it will decrease in the last 4 weeks, sharper and more rapid decline after 40 weeks if it passed the past term. The amniotic fluid is composed of 99% water, some carbohydrates, lipids, proteins, enzymes, mediators as cytokines, fetal excretory products, uric acid, urea, creatinine, sodium, chloride, together with vernix gaseosa and lango hair. Amniotic fluid characterized by having a clear aspect, pale color, slightly alkaline, pH is 7. So it's a colorless, normal, blood-streaked, reddish, traumatic tap or abdominal trauma or intraamniotic hemorrhage, yellowish, hemolytic disease of the newborn, dark green, meconium, maybe fetal distress or breech presentation, dark red-brown, fetal death. Function of the amniotic fluid is to protect the fetus from the external trauma, maintains constant surrounding temperature, medium for fetal movement, muscular development, and neuromuscular coordination. Source of fetal excretion and source of fetal nutrients, fetal lung distension and development, prevents the occurrence of intraamniotic bands, adhesions, and fetal compression deformities. Here, very important, preventive for the trauma. Number 2, neuromuscular development and fetal movements. This is very important for the development of the fetal musculature. It's a source of excretion. The baby swallowed, and breathe it. That's why there is a lung distension. Stomach will be full of amniotic fluid, and this will be a sure sign of an open esophagus here. Prevent the occurrence of intra-amniotic bands, adhesions, and fetal compression deformities. Evaluation of the amniotic fluid volume. Either amniotic fluid index, it does mean we measure the 4 longitudinal pockets at 4 quadrants and we take the sum, or amniotic fluid longitudinal pocket, the deepest vertical measurement. So, amniotic fluid index, it's either from 0 to 5, this is oligohydramnios, this is oligohydramnios, normal from 5 to 25, polyhydramnios more than 25. If I only measure one single deepest pocket, if it is less than 2 centimeters, it's oligohydramnios. From 2 to 8, it is normal. More than 8 centimeters, it's polyhydramnios. 2 diameter pocket from 0 to 15 centimeter, from 15 to 50, more than 50. This is the single pocket, vertical. This is the single pocket, vertical measurement. This is the 4 quadrant, this quadrant, another one, third, fourth, 4 quadrant measurement of the deepest longitudinal diameter. The sum of the 4 will be the amniotic fluid index. This is the 4 quadrant, 1 quadrant, second one, third one, fourth one, and the sum of this will be the amniotic fluid index. Amniotic fluid index, the average is from 16 plus or minus 5 centimeters, oligohydramnios less than 5, polyhydramnios more than 25. What about polyhydramnios, excess amniotic fluid, usually associated with diabetes mellitus, multiple gestation, RH isoimmunization, pulmonary abnormalities in the fetus, fetal anomalies like duodenal atresia and anencephaly and open neural defects, twin-to-twin transfusion, there will be 1 oligohydramnios and 1 polyhydramnios. Oligohydramnios, it does mean the deepest pocket is less than 2 centimeters. Usually fetal UT problems, renal agenesis, or genital tract or urinary tract obstruction, uteroplacental insufficiency, and premature rupture of membrane. This picture shows one of the complications. If you had oligohydramnios, usually the cord is compressed against the bony pelvis, so there will be some sort of a variable deceleration, decelerations with the start of labor. Oligohydramnios, it does mean diminished amniotic fluid volume, affect 3 to 4%. The incidence significantly increase in association with intrauterine growth retardation. This is the association, and the cause is usually placental insufficiency. History of rupture of membrane or leaking amniotic fluid may be present. Inappropriate growth of maternal abdominal girth, or the size of the baby is below the average. By examination, smaller size of the uterus and the fundal level is below the expected gestational age. Ultrasound, the largest vertical pocket less than 2 centimeters, or the amniotic fluid index less than 5. This is oligohydramnios. This is oligohydramnios. There is no amniotic fluid. It's either reduced production which is usually associated with placental insufficiency and hypertensive disorders of pregnancy, sometimes diabetes, or amniotic fluid loss due to rupture of membrane. Near-term or late preterm, especially if placental insufficiency and lethal anomalies. You have to terminate pregnancy for the sake of the fetal life. Amnio infusion, if you are very early, preterm, before 34 weeks, intra-amniotic saline injection from 250 to 300 milliliter will prolong the pregnancy and will prevent the problems, complications of Polyhydramnios. In cases of extremely preterm pregnancy, to avoid complications. This is a trans-cervical amnio infusion, or this is monitoring, scalp electrode monitoring, fetal monitor. This is the infusion pump. This is a trans-cervical, may be done amnio infusion. What about polyhydramnios? Polyhydramnios excess amniotic fluid volume, more than 25 milliliters in the amniotic fluid index. It occurs in 0.5 to 1.5% of pregnancies. It's either acute, which usually develops very early in pregnancy and usually associated with major congenital anomalies of the baby, and the abortion is usually the fate or termination. So it's rapidly accumulating amniotic fluid less than 20 weeks, early symptoms, associated with uniovular twins or major fetal anomalies, and mostly in abortion. Chronic polyhydramnios, it's a slowly accumulating amniotic fluid more than 24 weeks of gestation, less serious, less symptoms, mostly idiopathic or may be associated with gestational diabetes mellitus and multiple pregnancy, RH isoimmunization and fetal hydrops for different causes. Pregnancy is usually completed successfully and in. What about the diagnosis? Progressive rapid enlargement of the abdominal girth, especially the third trimester, maternal respiratory embarrassment and the pressure symptoms in early severe cases. By inspection, the abdominal girth is actor من gestational age, the fundal level more than the gestational age. Fetal part cannot be felt easily. Positive tap test thrill. Ultrasound, largest pocket more than 8 cm or amniotic fluid index more than 25. It's either mild, moderate if it is more than 12 centimeters, severe if the single pocket more than 16 centimeters. So it's mild, moderate, and severe. This is the polyhydramnios. This is amniotic fluid index. Risk is preterm labor, fetal prematurity, dysfunctional labor, and placental abruption if associated with sudden rupture of membrane. Mild and moderate polyhydramnios exclude gestational diabetes, this is very important, and congenital anomalies, this is very important. Conservative treatment till spontaneous labor starts, reassurance and follow-up. Severe polyhydramnios, if it is term, you have to terminate pregnancy by induction of labor or cesarean section. If preterm, we can do amniocentesis, removing from 1 to 1.5 liters every time will prolong pregnancy until lung maturity is established. This is the amniocentesis, usually ultrasound guided to avoid placental tapping, and you will remove from 1 to 1.5 liters of the excess amniotic fluid. The last subject we are going to discuss is the fetal birth injuries. It's an important, commonly avoidable cause of neonatal morbidity and mortality. Variable, minor skin abrasion to intracranial hemorrhage, which is more serious. Prevention of serious trauma. It depends on the experience of the obstetrician and the reflection of the improvement of the antenatal care and the perinatal care programs. Bone injuries, it's either skull fracture due to forceps application or delivery through a contracted pelvis. The types of fracture vault, either a linear fracture or depressed fracture, or fracture base, and usually depressed fractures and fracture base associated with intracranial hemorrhage, or fracture mantle. Other long bones like spine injury, especially in breech presentation, fracture humerus, fracture femur, fracture clavicle, or dislocation of the hip or dislocation of the shoulder. This is the linear fracture. Soft tissue injury, the most important is the intracranial hemorrhage, usually associated with compressed fracture of the cranial bones. Cephal hematoma, it's usually due to the periosteal, subperiosteal collection of blood. Nerve injuries, facial nerve palsy due to forceps application, brachial plexus injury due to breech, delivery, or excessive traction on the shoulders, visceral injuries like liver or spleen during breech delivery, muscle injury like the sternomastoid, one of the commonest site, eye injury, injury of the hymen and the anal sphincter, usually with the breech, skin and scalp injuries, and this is usually occur with cesarean section. It's due to scalpel during uterine incision. Intracranial hemorrhage is one of the most serious and leading cause of neonatal death. It's either associated with prematurity, fragile blood vessels, defective coagulation, very rapid compression and decompression during delivery, or breech delivery, sudden compression and decompression of the cranial bones during the delivery of the head, rapid delivery of the head, excessive compression due to forceps, asphyxia and hypoxia will lead to hypoxia of the blood vessels and the fragility, hemorrhagic disease of the newborn. It's either intraventricular hemorrhage or intracerebral hemorrhage, which are very serious and deep, or subdural hemorrhage or subarachnoid hemorrhage, which usually associated with traumatic delivery. This is lobar intracerebral hemorrhage. This is subarachnoid hemorrhage. This is the subdural hemorrhage. This is deep intracranial hemorrhage. This is extradural hemorrhage. This is the least serious type. What about the clinical presentation? Usually the neonate is either stillbirth or neonatal asphyxia. The baby is drowsy, refuse suckling, sudden sharp cry, convulsions and rigidity, tense bulging anterior fontanelle, vomiting. Brain CT is diagnostic. Prevention by giving vitamin K and careful forceps application. The treatment is resuscitation with minimal handling, chloral hydrate or magnesium sulfate or luminal phenobarbital to decrease the convulsions, sodium chloride per rectum for edema, it's a dehydrating measure, and other dehydrating measures including lumbar puncture, vitamin K 1 mg intramuscular, penicillin as a prophylactic for infection. How to differentiate between edema that develops under the scalp and in the scalp, or kephalhematoma, which is a hemorrhage subpreostia. Caput saxtina usually occurs in edema, occurs in obstructed labor and ventouse delivery, while kephalhematoma usually with the forceps or the ventouse with difficult vaginal deliveries. It appears at birth, while the kephalhematoma usually takes few hours to 1 day to start. The edge here is ill-defined, it's an edema, may be ecchymotic, overlap sutures cover more than one bone, while this is a well-defined, skin over it is normal, and it is restricted to one of the bones. There is no complication of the edema, caput saxtina, while the kephalhematoma, it will be calcified, infection may occur, and neonatal jaundice and hyperbilirubinemia may occur. Here the treatment is no treatment. Treatment is expectant or conservative treatment. Would this appear within few weeks? This is the caput, while this is the kephalhematoma. This is the caput here. Forcible traction of the cord of the head will lead to scarring and contraction of the sternomastoid. This is a muscle injury. It will lead to a sternomastoid tumor, torticollis, in the neonate. Or here, Erb's palsy, traction on the shoulder, it will lead to Erb's palsy, upper or lower brachial plexus injury. Forcible traction of the head, it will lead to sternomastoid hematoma and sternomastoid tumor. It may subside or cause permanent torticollis. Treatment by passive stretching of the muscle several times a day and physiotherapy and hot fomentation. Brachial plexus injury, the cause is aggressive traction, usually in shoulder dystocia. It will lead to injury of the brachial plexus. It's either high C5 and C6, and this will lead to Erb's palsy, or lower down clump K, which is injury of C8 and T1. Policeman tip position, Erb's, adduction, internal rotation, and flexion of the wrist. The lower brachial plexus injury, clump K palsy, rest drop, absent grasp reflex, and paralysis of the small muscles. Physiotherapy and plastic correction may be needed. Facial nerve palsy, compression of the nerve by blade of forceps. Clinical picture, unilateral or temporary, absent nasolabial fold, angle of the mouth is deviated to the healthy side, absent blinking of the eye. Treatment is conservative, sometimes corticosteroids, and thank you very much. Thank you.